Welcome back, everybody. I think we're going to get started with the next session in the interest of time. So again, my name is Sanam Loghavi. I'm a hematopathologist from the United States.
And I'm Sebert from France, Hôpital Saint-Louis.
So this session is going to focus on classification systems for MDS. We will talk about the WHO, the ICC, and the hopefully a harmonized classification for the next iteration. I have the pleasure of introducing Dr. Ulrich Germing from Germany, who is going to speak to us about the WHO 5th edition, so the WHO 2022.
Okay, dear Sanam, cher Marie, bonjour. Thank you for inviting me to share some thoughts on WHO 22. The majority of this is no in my case. I would love to start with some thoughts of three dimensions. The first one is to make a diagnosis. The second one is to find a classification. And the third one is the prognostic consideration. And this is not the same. The classifications try to find homogeneous groups with regard to morphology, chromosomal, molecular things, as we heard before, and not primarily to find a prognostic category, because prognostic categories are usually heterogeneous because classification types run into different prognostic types. So let me start with 5 characteristics of myelodysplastic syndromes. For example, here the increased blast, micromegakaryocytes, del5q, TP53 mutation, F3B1 mutations. You can use these categories for diagnostic features, but nothing of those is MDS specific, so you cannot rely a diagnosis on one of these 5 categories. You can use this for classification, but only in special circumstances. For example, the del5q in the classification is allowed only with isolated or +1 non-7, and if the blasts are low. And you can use them for prognostic assessment, and again, only in special circumstances, not as characteristics as standalone things. You all know the WHO 22. I will go into details, but I want to draw your attention on 3 absolutely new categories that were filled in here. It's the hypoplastic low blast myelodysplastic syndromes with some therapeutic implication, low risk of evolution to AML, but it's not easy to, in every case, to separate from aplastic anemia. The second category is also a morphological type, a histomorphological type. It's MDS with fibrosis and increased blast. This has prognostic and therapeutic implications on high risk of evolution and high risk of high-risk genetics. And the third one is the first category, the biallelic TP53 alteration, a molecular type, regardless of any other things. Number 4 is the WHO get rid of the MDS unclassified types. This was a chaos before, so they omitted these things. So the methods that we have to go through is cytology. We heard an excellent talk of Dr. Loghavi minutes ago. Histology is mandatory. Karyotyping, mutational panel of blood or marrow. Flow cytometry is not addressed sufficiently. Ariane alluded to this point an hour ago. The VAF of somatic mutation is not addressed sufficiently in the WHO from my perspective. Parameters of inflammation and stroma is not addressed at all. So there's room for improvement, definitely. I want to draw your attention on the hierarchy of the diagnostic findings. So first one is TP53B, because regardless of any other character that we see in the cases, this makes the diagnosis. Number 2 is the increased blast of blood and marrow. Number 3 is fibrosis. Number 4 is del5q and other karyotypic findings. Number 5 is F3B1 or ring thoracic phenotype. Number 6 is celerity, and number 7, last but not least, uni versus multi-lineage dysplasia. So WHO clearly defined this hierarchy should be taken into account. This is the entire figure of all the types, and in yellow you see the defining events. This is multi-TP53. These are the increased blast, fibrosis, del5Q. So they run the classification primarily. I shortly want to go with you through some of the data that Katrin Nachtkamp from our group, she's sitting here in the room, put together with the German, Austrian, Swiss MDS group and validated both the WHO and the ICC, and I concentrate on the WHO here. The first thing is there's a reclassification from all these types here to p53 allelic and to MDS fibrosis. And some of the MDS use, unclassified, run here into these categories. Some others get read into the CHIP category. And we lose some patients, about 10%, into the oligomonocytic leukemia category that was defined by both WHO and ICC. And the result of this refinement of the CMML is that about 5% of the SLD, 8% of the MLD, 18% of the SF3B1s end up in the oligomonocytic leukemia category. Even some del5Q end up there. Of course, no hypoplastic, no MDS fibrosis, no B-allelic TP53, but again, 6% of the IB1 and IB2 end up in CML1 and 2. So we lose some patients to that category. And it was a topic in the last session if this newly diagnosed and defined oligomonocytic leukemia is in between MDS or CMML, and to my point of view, it's a mixture of both. So we have to work on this oligomonocytic CMML type again. Another thing is the post-cytotoxic MDS cases. They come from all the other categories where the primaries were defined. And even in the SLDs, they were 3.5%. In the MLDs and the hypoplastic, 10% of the hypoplastic MDS end up in the post-cytotoxic cases category. Even some SF3B1s, del5Q, 12% of the biallelic TP53 alterations, and of course, EB1, EB2, and MDSF, again, 12% post-cytotoxic cases. So I started to say it's not the main focus of a classification to come up with prognostic things, or to replace IPSSM or whatever. This will never happen. But WHO, likewise the ICC, came up with the proposals that have prognostic implications. As you can see here, SLD, 69% survival, MLD, 42, hypoplastic, 50, del5Q, 75, SF3B1, 63. So there is some prognostic implication in these categories. The same is true for the risk to develop an AML in the MLD, SLD, and hypocellular cases, and the risk to develop an AML is lowest in the SLD group. This is not surprising. When we now focus on the genetically defined categories, this is no surprise, del5Q, SF3B1 run very good in the long term. Don't forget, these are not 500 days, but 500 months, as the registry runs for 40 years now. But these are the B-allelic TP53s, and they have a disastrous outcome. Why is that? It's because of an extremely high progression rate to acute leukemia in this category, very low in the SF3B1, and this is well known, about 20% of the del5Qs end up in acute leukemia. Let me come to the degree of dysplasia within the group of SF3B1. And there was a debate in WHO, and I think, Bob, also in the ICC, whether we should separate them purely morphologically. And what we can state with confidence is that dysplasia plays a role, And the major reason for that is that the multi-lineage dysplastic patients are more B and pancytopenic, have higher risk of abnormal karyotype, and very high and high risk karyotype according to IPSS is 4.5 to 16.7%. And of course, AML evolution and overall survival times differ significantly. So we should not forget that dysplasia plays a role in this category as well. What we have to do, and what some others did, is to correlate these findings with the SF3B1 mutation status, yes or no. There will be a report from Italy, the evil of the SF3B1s, negatives, ring sideroblastics. They obviously behave worse as compared to the SF3B1 positives. When we look to the high-risk MDS cases here, namely EB1, EB2, MDS-F, and as a comparator, AML-MRC, and these are patients with a very long follow-up. Of course, there are patients who have been treated with HMA, with allogeneic transplantation, but again, there are tremendous difference between IB1, IB2, MDS-F, B, and the AML-MRC group. When we look to the risk to develop an AML, you can see that the number of blasts at diagnosis plays a role with regard to the risk of AML evolution. This EB1, EB2, and MDS-F is even higher than the others. So it makes sense to separate the fibrotic blastic MDS as a separate entity with regard to the risk of AML evolution. Very shortly, there will be an oral speed-fire session from Katharina Mont from Düsseldorf. These are patients with IB1, 2, and AML, best supportive care only, reflecting the biological cause of the disease without treatment. And you see there's a tremendous difference between these three. And this is the disease biology, not the treatment. And Katharina will go further on in this speed dating session, speed fire session. Sorry. With regard to the treatments. So let me shortly concentrate on the red signs here. This is EB1, 2, fibrosis, B allelic, and AML. And you see the dropping cell counts correlate with the number of blasts. So the enumeration of the blasts obviously play a role. The percentage of peripheral blasts or the presence of peripheral blasts correlates nicely with the categories. Look at 60% peripheral blasts, in the MDS fibrosis category. And of course, the karyotypic anomalies go up from EB1 to MDS fibrosis and of course B allelic, because the majority of them has 70 minus or 70 P minus. Okay, this is, from my perspective, a very important a paper from Julia from Spain. She put together del5Qs and analyzed the impact of TP53. And as I mentioned before, we have to deal with the variant allele frequency, not only here, but also in the other categories and the other genes that are mutated in different VAVs. And here you can see that it doesn't make a major difference with regard to overall survival if TP53 is mutated in the del5Q, not in the entire MDS population here, but it plays a role with regard to AML evolution. In the second step, they separated monoallelic TP53 from B allelic, and again, the AML evolution rate is higher if a TP53 is mutated or alterated biallelic. And here, they introduce a VAF of plus or minus 20% as a separator. And in this category, if the TP53 monoallelic mutation has a VAF of more than 20%, these patients more or less behave like TP53 multi-mutated. So I think we have to go through all the categories and all the genes and all the VAFs to come up in the future to see if they play a role and how to handle with. The ICC started this to do, and Rob will give a talk in a minute to that. What we finally did, we put all these hundreds of patients into a multivariate analysis with regard to overall survival, and no surprise, these are the categories that play the major role, whereas multilineage dysplasia is still in the model, but loses, let's say, weight in the multivariate analysis. So, to sum up, MDS 22 in a real-world classification set is feasible and robust. We could easily reclassify more than 2,000 patients from the registry of, I think it was 15 centers in Germany, Austria, and Switzerland. So it works fine in reality. The new 3 subtypes are specific, and we should discuss later with Amer, who will discuss the reorganization of WHO and ICC in the future. And from my personal perspective, we should retain the fibrotic type, at least. And from my personal perspective, IB2 and AML should be kept as separate entities, because if you don't treat them, they behave different. And in reality, the majority of the AML receive chemotherapy, and the majority of the EB2 don't receive chemotherapy. They receive a hypomethylating agent plus or minus Ven or plus or minus something. So we do different things to these categories, and so it's not easy to put all these patients in one category, because people may think, well, this is one story, I fill in some drug ABC and see what's happened. This is not a good idea. We should refine and validate the classifications, not take into account the therapeutic considerations and the result of the treatments on the disease, course of disease. We should integrate all diagnostic methods and potentially new methods, and we should develop the reharmonization very smart. Thank you for your attention.
Sorry about this. We'll take questions after the 3 classification sessions, talks. Go ahead.
Thank you. So the next speaker is Robert Hasserjian from United States of America, and the talk will be on ICC 2022. Thank you.
Thank you very much. It's a pleasure to be here, and thank you for the opportunity for allowing me to present on the ICC classification of MDS. And as you heard from Ulrich, it's not very different from the WHO, but there are some differences that I'll highlight. So these are my disclosures. So just so we're all on the same page, myelodysplastic syndromes are defined as clonal neoplastic bone marrow proliferations. The ICC still calls them syndromes, but we all recognize they are neoplastic. They replace normal bone marrow hematopoiesis and display ineffective hematopoiesis, resulting in peripheral blood cytopenias required for their diagnosis. Disordered maturation, which is reflected by both dysplastic morphology we see under the microscope, and, as we heard from Arjan, immunophenotype, which is expected because abnormal morphology is because of abnormal proteins and cytoskeleton, which can manifest also as cell surface markers in blasts and in maturing cells by flow, and abnormal function of effector cells, giving rise to complications like infections. We also know they contain a variable portfolio of genetic abnormalities, including mutations and cytogenetic aberrations, usually involving that are unbalanced. So this journey from clonal hematopoiesis to myeloid neoplasia, we've heard a lot of talks already in this session about clonal hematopoiesis, which initially says CHIP, there's normal counts and normal morphology. Then the patient may become cytopenic and we have CICUS, but then there's some combination of events which gives rise to something that looks abnormal under the microscope and causes cytopenias. This is probably a combination of particular combinations of genetic abnormalities, epigenetic factors, and microenvironment that we call that disease MDS. But I think it's a little bit more hazy than that, because I think CCUS and MDS lie in a continuum, which we are still, until now, choosing to separate by the dysplasia we see under the microscope. And we have a threshold of 10% dysplastic cells retained by the ICC and the WHO. But as we heard from Sanam, dysplasia is an imperfect diagnostic feature because it can be mimicked by other things. However, as of at least 2022, it's considered as the best diagnostic indicator we have, and it's currently being used in both ICC and WHO as a separator between CCUS and MDS. So just to reiterate the borders of MDS, again, between the clonal cytopenias, things like Vexus even, or anything, you have to have 10% dysplasia to call it, for example, Vexus plus MDS, or CCUS to go to MDS. We also have to think about the border between MDS and MDS-MPN, and these are the current thresholds. There's the monocytosis we've already heard about, but also if you have a white count over 13,000 that's sustained, or platelets over 450, those disqualify MDS and force you to classify this as an MDS-MPN according to our current guidelines. And then we heard about the 20% blast count tradition, which is still maintained by ICC. However, the ICC did introduce an intermediate category of MDS/AML, as Ulrich alluded to, and I'll talk a little bit more about that later. So these are our borders that define sort of the box of MDS, if you will. But we have to keep in mind these are not static. Things can progress. So CCUS can progress to MDS if a pathologist calls dysplasia. And then MDS can progress to MDS-AML or to frank AML if it crosses those blast thresholds. But the ICC forbids a transition for MDS to MDS-MPN. That's retained from the 4th edition WHO. If an MDS case develops, say, monocytosis or leukocytosis that's sustained that wasn't present at the time of initial, you still call it MDS, but you will then say it has CMML-like progression. This is an area that I think deserves more exploration. I know the WHO actually allows a subsequent diagnosis of CMML, whereas the ICC decides to retain it in MDS, and I think that's an area that's very interesting and warrants further study. Often it's accompanied by the acquisition of, for example, RAS pathway mutations. So just briefly, we already heard a beautiful talk about morphology, but in terms of the ICC, retains the 10% threshold of dysplastic cells, but this is not a perfect threshold, and it's already been interrogated for megakaryocytes, been proven in a couple of studies that 10% is not really specific enough, that a criterion of a 30 or 40%, if you count all types of dysplastic megas, is probably more appropriate. So in other words, you're too loose if you use 10%, and you may overcall dysplasia. However, micromegakaryocytes, which we often identify using immunostains, as shown here, are quite specific for MDS. And so I always stain for CD61 and look for those tiny megakaryocytes that are much more specific for MDS. But even if you see dysplasia over 10% or even over 40% for megas, these can be mimicked by non-MDS conditions. And it's been shown in normal volunteers can have more than 10% dysplasia, and it's even more common in non-neoplastic cytopenia. So this 10% dysplasia threshold must be applied with caution and an understanding of the clinical background. We already heard about flow cytometry, but I just want to mention, as Arjan did explain, that neither the ICC nor the WHO formally accept flow cytometry abnormalities alone as diagnostic of MDS. They're supportive. As we heard, we need to do flow on an MDS bone marrow to exclude MDS mimics like hairy cell leukemia or LGL leukemia. But there are certainly numerous studies that have shown that, as you saw from Arjan's lecture, that show that flow cytometry can predict MDS with good sensitivity and specificity. So I think based on recent recommendations for the ELN International, which happened after the WHO and ICC sort of already made their decisions, these very compelling studies, I think, suggest that flow could be incorporated alongside morphology as a diagnostic criterion into future MDS classification. I think that's a very reasonable thing to consider. And then what about the role of genetic testing? So you all are aware there are mutations that occur in about 90% of cases of MDS. We'll have at least one mutation or cytogenetic aberration. We have to keep in mind that some of the most common cytogenetic abnormalities are not specific for MDS. So trisomy 8, loss of Y, deletion 22 can be seen in non-neoplastic conditions. So you have to be cautious about using those to diagnose MDS. So the ICC, unlike the WHO, does permit a diagnosis of MDS in the presence of certain so-called MDS-defining genetic aberrations. And this is actually inherited a bit from the 4th edition WHO, which had a longer list. This has actually been simplified in the ICC to only include deletion 5q, abnormality of chromosome 7, complex karyotype, and then 2 mutations, SF3B1 and biallelic P53, if they occur at a VAF of more than 10%. I should emphasize this is so-called MDS without dysplasia defined by mutations. These are very rarely invoked, and I think many times the lack of dysplasia may reflect a poor sample, a bad bone marrow, and I think the ICC retained these to allow a diagnosis if you have, for example, a very high biallelic P53, patient's very cytopenic, it allows you to, gives you some freedom to make that diagnosis, even if you're not able to identify the dysplasia. But I think more loosely speaking, I think we do use genetic data to support an MDS diagnosis already suspected on morphology, especially if we see multiple mutations at high VAFs. And I think this is just something to keep in mind. And just a word of caution, we've heard a lot of very nice studies about CCUS and risk scoring, and many of them use an endpoint of progression to a myeloid neoplasm, progression to MDS from a CCUS or a CHIP. I would be cautious because just to be aware, your pathologists that are making that call of a progression are using genetic data, so it becomes a self-fulfilling prophecy. So I'm biased. I have to admit, if I look at a slide and the megas look okay, and then I see that there's 5 mutations at high VAF, B-core, various things, I look again, it's like, wow, you know, these megas look kind of atypical. So then I might be willing to call it MDS. So I think you have to be a little bit careful about that. So I think, and this is an area where perhaps image analysis, computer assisted, that's not going to be as biased, maybe assist us in being more objective in how we interpret morphology. Conversely, absence of mutations can be reassuring and stimulate a deeper search for non-MDS causes of the cytopenia. But about 5 to 10% of bona fide MDS, as we heard from Elsa's talk, have a normal karyotype and lack mutations, even on quite large NGS panels. And these are really MDS, and we've studied this and found that these have similar behavior to lower risk MDS. So I think they're not false MDS as they really are, and this indicates that probably they're assumedly clonal, and they may just have mutations that are not common on the panels. So now to get into the actual subtype of MDS, I've talked about the borders of MDS. What about the classification? I think you're already now familiar with this. I'm just highlighted and read some of the new entities in the ICC, which are essentially similar to the new entities that were added in the WHO, except the ICC did not add fibrotic or hypoplastic MDS. But it is like the WHO an algorithmic process. This is how the algorithm works for the ICC. Obviously, the minimal criteria is cytopenia and at least 10% dysplasia. And then we have genetic and morphologic determinants of subtype, and the first decision is whether or not there's a P53 mutation, like the WHO. And this should be multi-hit or biallelic to define the entity of P53 mutated MDS. You've already heard about this. It's associated with cytotoxic chemotherapy in about half of cases. It's almost always associated with a complex karyotype due to very complex cytogenetic aberrations which occur once the P53 becomes biallelic. It's often the sole and founding mutation, and it can present as many different MDS morphologic subtypes. So this is the ICC entity, defined as cytopenic patients with the multi-hit P53 with a VAF of at least 10%. It supersedes all other MDS subtypes. It's irrespective of the blast count and considered together by the ICC an overall group with P53 mutated AML. And the reason for that is because studies that we and others have done that have shown that no matter what the blast count is, patients seem to do very poorly, at least in the real world studies, patients that get treatments. Now, the IC does allow a single-hit mutation when the VF is more than 10%, and that's based on prognostic studies, for example, by Grab et al., that showed that when you have excess blasts or frank AML, monoallelic mutations seem to do as poorly as the ones with biallelic. I personally don't like this because I think the true biologic entity is the biallelic mutation, and I think you can apply things like IPSSM that will pick up, or the ELN classification for AML that will pick up the monoallelic ones that will put them in the poor risk. So I think the classification should be based on biologic entity rather than prognosis, but this is the ICC, and I don't agree with everything in the ICC, but this is how it defines it. So this is just a comparison briefly of the ICC versus the WHO fifth for the P53 entity, which is a bit, I think, confusing, but tries to spell it out. They both accept cases from up to 19% blasts, both require biallelic P53 and minimal morphologic dysplasia, but the ICC has some additional features which are added in there that allows, it's a little bit looser in a sense, and that allows, again, monoallelic mutations for some cases. It allows cases that don't have morphologic dysplasia if there's a cytopenia, and it also allows complex karyotype as a surrogate if you don't know the loss of heterozygosity status defined by allelic. The WHO is a bit stricter in its genetic definition, however, it does allow cases that have a lower P53 VAF. I just reiterate what Sanam also said, is that the current criteria we use to define biallelic P53 in both ICC and WHO are only an approximation. They're imperfect. Many labs don't use copy-neutral LOH assessment. Our lab does, fortunately, but many do not have access to that. So these will be missed in standard assessment. The 50% cutoff is not necessarily a be-all and end-all. And also, you could have two mutations of P53 that are in cis, which may not be picked up if they're far enough apart by NGS, or two monoallelic mutations in different clones, which may simulate a biallelic. So I think we still need to work better, and single-cell testing is the ultimate way that we may be able to pick up those cases. So then moving on to the next group is the ones that have excess blasts. And I think we're all aware of excess blasts. And I want to just say a few words about the ICC entity of MDS EB2, having 10 to 19% blasts in the marrow or blood. It was really not reclassified. It was just renamed MDS/AML. And this is not saying the new boundary of AML is 10%. It creates a sort of an intermediate group which acknowledges that there's some continuum between MDS and AML. The 20% threshold is arbitrary. I think blast behavior is a continuous variable. And as the blasts increase, the prognosis gets worse in patients that don't receive in the natural history, as Ulrich showed. And also, there's some imprecision in counting blasts, and this is shown by these sort of Kepke values, which show the imprecision. Even if you perfectly count blasts, which is debatable, even if I count 500 cells as recommended, and I count exactly 20, the actual range is quite wide. So these patients really may not be, if I count 21, they may actually be 18. So it acknowledges that it may be imprecise and tries to create this intermediate area. The idea is to expand treatment options, not to suggest that all patients that have 10% blast should receive 7+3, but say that these patients may have more eligibility for AML treatment. And I think certainly trials are needed to look at how these patients respond and determine which patients, if any, should be treated with more intensive therapy, whether 7+3 or aza-ven. This could be based on their genetic signature, their tempo of disease, or de novo plus secondary, but unless we study them and sort of think of them as a group, we may not ever discover if some patients may benefit from more intensive therapies. And then we have the genetic subgroups of MDS, SF3B1, and other lower risk genetic subtypes as shown here. I won't talk about deletion 5q, but I will mention SF3B1, which replaces most cases of MDS with ring sideroblasts. So this could have single or multilineage dysplasia. There are certain exclusionary features, including RUNX1, which may partly explain the worst prognosis of the multilineage dysplasia, because the ICC specifically excludes RUNX1. And this is undoubtedly more biologically heterogeneous than the prior MDS with ring sideroblasts. Unlike the WHO, an ICC ring sideroblasts cannot substitute for SF3B1. Cases with ring sideroblasts and wild type are classified elsewhere, many in AML NOS, but some actually I want to mention, you have to be careful about if you see ring sideroblasts, because the second most common mutation that is associated with ring sideroblasts is actually biallelic P53. So if you see ring sideroblasts, especially if there's severe dysplasia, this may actually be the worst MDS instead of the best type of MDS. So that's why at least do a P53 immunostain if you don't have access to NGS. And this shows that if you have ring sideroblasts and it's SF3B wild type, the prognosis does not seem to be different for MDS NOS. And that's why the ICC discarded ring sideroblasts as a classifier in the new classification. Then finally, there's the morphologically defined, or MDS, with single or multilineage dysplasia. And this has been retained, as Ulrich has also mentioned, because in multiple studies, there's shown significant prognostic separation between multi and single lineage dysplasia in multiple studies. And that's why the ICC retained that as a classifier in the ones that don't have specific genetic abnormalities. However, I think further study needs to be done to see if this will retain prognostic value that's independent of genetic risk. It may be that when you apply IPSSM, that SLD versus MLD no longer has significance. So finally, the qualifiers. ICC applies these in a structured way, and the two possible qualifiers are therapy-related or post-cytotoxic therapy, or a genetic background of predisposition. So you first classify according to sort of ignoring the genetic background. You give it its name, MDS with deletion 5q or whatever, and then if the patient has a history of therapy, you add those on as additional qualifiers for the diagnosis. So that's kind of how the final classification scheme looks, with the qualifiers added at the end. Now, I just want to end with two slides, philosophical slides. One thing I don't like is this separation of morphological determinants of subtype and genetic determinants of subtype, implying there are these two sort of types of MDS, morphologically and genetically defined, like the two twins, Romulus and Remus of Rome. They're somehow two alter egos of MDS. I think morphologically defined MDS really just represents cases whose genetic signatures have not yet been adopted as specific disease classes. And we heard from Elsa's beautiful talk, there are candidates in the future that we may want to consider as classifiers for these so-called morphologically defined cases. And this has been shown in other unsupervised clustering studies, which has shown that even MDS with excess blasts has different genetic signatures that perhaps should be used instead of throwing them all together in one group. And some of these may also represent, for example, progressed MDS with deletion 5q. So I think rather than the Romulus and Remus, MDS is more like Janus. It has two faces, morphologic and genetic features, and ideally our diagnosis should express both biologic attributes of each case, the biologic attributes of each case that could inform a treatment approach beyond just the prognostic risk score. So I think in the future, this is again looking towards the future, I think each MDS diagnosis should incorporate a genetic class, which we could use, for example, the classification when validated that Elsa presented, depending on the classes as they get validated. I think each case should have morphology. I think percentage of blasts still may be important, for example, to look for response criteria. And blast behave as a continuous variable and may represent a stage of disease that you've heard about. I think fibrosis, hypoplasia, SLD, and MLD should still be included as well, but alongside rather than replacing the genetic class. And finally, the clinical ontogeny should remain in the background. It may inform selection of a donor, the type of therapy the patient can tolerate for conditioning for transplant. So this is finally my last slide. I just want to end on a positive note. Light at the end of the tunnel, as you've, I think, heard alluded to. The 6th edition WHO classification of myeloid and lymphoid neoplasms is just around the corner. It's due to begin in 2026. Now, as a representation of the hematopathology societies, I was president at the time. We started a detente with the WHO leadership, and this is subsequently taken over by Carlos Bueso Ramos, the current president, and we reached agreement with them on a process to return to a single classification. And this is going to be a two-step approach where the societies plan a classification advancement meeting, or CAM, which is being planned for early 2026 ahead of the anticipated WHO 6th edition preparations. The steering committee is being formed, which will include both ICC and WHO contributors. The meeting will eventually assemble over 200 hematopathologists, clinicians, and geneticists. We'll analyze critically the differences between the ICC and the WHO, try to integrate new data, and develop guidelines for new classification that then will be published and then will serve as a basis for the subsequent 6th edition WHO that I think will be accepted as the final classification. So I think that's a happy ending of this current rift to bring them together, and so I think that's something we have to look forward to in the future on the horizon. So thank you for your attention. Sorry I went a little bit over, but...
Thank you, Rob. And on that note, we're going to invite Dr. Amer Zeidan from Yale in the United States to speak to us about a harmonized classification system. Amer, welcome.
Thank you so much, Sanam, and thanks for the organizers for the invitation to talk about our project to try to harmonize the classifications systems. And I just wanted to introduce the International Consortium for MDS because some of you might not be familiar with this, but it's actually a global expert think tank. It's from many countries across the world that have come together. This officially launched in 2022 after a long delay because of COVID. We finally had our in-person meeting in Miami in 2022 in June. And actually around that time, many of you remember that two different classifications, the WHO and the ICC, has come only a couple of months before then. And I remember very well Dr. Hasserjian actually being tasked with the not very pleasant task at the time, I think, of showing us the differences because there was a lot of disgruntling between the clinicians about having two different classifications. And the ICMDS really is a venue to try to exchange ideas, knowledge, and research in MDS with the goal of enhancing collaborations across different disciplines and to provide a united voice from the scientific and the research community to try to improve clinical trial design and conduct and allow robust interactions that eventually between all stakeholders with the ultimate goal of providing more effective and safe drugs that can help our patients. And I want to emphasize here that this consortium was never intended to be competing with other groups or other consortia or the foundations. We think of it as a complementary mechanism where we think about expert input in terms of trying to promote the research agenda. And as I mentioned, when these classifications were published in 2020, I think there was a lot of concern, I think for good reasons, and I'm going to talk here on behalf, I guess, of clinicians or clinical researchers. I'm not a pathologist, I'm not a morphologist or cytologist. So I think when it comes from our end, I think there are several problems that come from having multiple classifications. And I understand this is a common occurrence, I guess, in lymphomas and maybe other conditions in the past, but for a very long time, we always had the WHO until 2022, and this is our common language. This is a language that pathologists, clinicians, patients, researchers, regulators, insurance, registries, all of us talk with each other using this common language. So to have two different versions, I think, was going to cause concerns. It's going to hinder diagnostic consistency, confuse and increase the anxiety of patients. And I can tell you, in the US, we have this system where the pathology report, the minute that the pathologist actually signs the report, gets released to the patient on their electronic device. So sometimes they see the diagnosis before we even see it. Sometimes if there's a conflict between what they were told based on the different classifications, this, I think, creates a lot of anxiety as well as complicate the communication between different parties. So in the first ICMDS meeting in 2022, we agreed on a top priority research items to try to resolve over the next 10 years. And one of them, as you can see here, was to try to advocate for one classification way for patients with MDS. Now, I want to emphasize here that this paper has already been published after 2 years of work. It's in Lancet Hematology. I'm going to show you like the main methodology that we took in this paper, as well as the main results, but this was a huge collaborative effort, and I wanted to emphasize the method because I understand the two classification. I'm sure there was a reliance on a lot of information from different places, but it wasn't clear to me how the final decisions on any of those categories or the cutoffs were made. Was there any evidence-based consensus approach? So the way we wanted to approach this issue was to work on a large database and then use an evidence-based approach using artificial intelligence to try to answer some of the classification questions. And this project, which was a large collaboration across the Atlantic, was really primarily led by the Italian group, Dr. Luca Lanino and Matteo Della Porta, who can give this talk much better than I can. Luca, actually, we are very lucky to have him now doing postdoc at Yale, and we are hoping to build up on these collaborations even further in the years to come. So the goal of this process was to develop a hierarchical and harmonized classification based on a comprehensive data set using advanced statistical methods of inference and artificial intelligence to come up with a harmonized system. So this is an overview of the methods. So we started by creating this data set, which included more than 7,000 patients from both Europe and the US, and then we classified those patients who were initially put in the data set based on the 2016 classification of the WHO. The patients who were reclassified based on the 2022 ICC and WHO classifications. We then validated both of those classifications, and both of them validated well, actually. And then we went into the harmonization approach based on hierarchical clustering with feature extraction and to try to develop the evidence-based part of this project. And for the areas that were not kind of clearly directed by high-level evidence, we went into a consensus-based process where we included 71 experts, and we used a modified Delphi process to try to reach a consensus. And here you can see the baseline characteristics of the cohort that was included in this project, 7,017 patients, typical features for MDS based on age, and the distribution by the 2016 classification, as you can see, all the known entity. And you can see the overall survival of those patients as well as the mutation distribution. I think kind of goes very well with what you expect. So I think this patient sample was clearly very representative. I would highlight here that, as you can see, those patients were treated in different ways according to their risk groups, using ESAs, HMA, lenalidomide, or allogenic bone marrow transplantation. So we started, as I mentioned, by validating the prognostic relevance of both classification. And as you can see, both the WHO and the ICC classified very well in terms of their ability to predict prognosis. Patients who had SF3B1 mutated MDS clearly had the best prognosis, and those who had biallelic or multi-hit TP53 had the worst prognosis. And then we tried to kind of see the overlap or the reclassification between the two systems. And while there was a significant overlap, as you would expect, there was some degree of discordance in a significant number of patients, 45%, although many of these switches were minor. In the genetic subtypes, the switches were minimal, 19%, but there was more discordance in the morphologically defined entities, which was around 56%. And then we took the second step, which is to use the artificial intelligence methodology to develop these clusters, and we came up with these 9 clusters here that you can see here. Some of them are, I think, what would be expected based on the classifications you heard about, the SF3B1, the biallelic TP53, as well as the del5Q, and then others that I think were a little bit less common. And I think this issue, again, overlaps a little bit with the taxonomy project that you heard about from Dr. Bernard and others. But I think it's clear to me, and I think this is what Dr. Hasserjian mentioned as well, is that there are other genetically defined entities within MDS beyond the 3 that have been described so far that probably will be included in subsequent classifications. I think having 16 is practically not kind of feasible, but we have to agree or come up with a process where we define, I think, a limited number of these genetically defined subsets that could be used clinically, whether for research or for clinical trial development. So the entities, and I'm not going to go through a lot of this in detail because, again, there's a significant overlap, but that biallelic TP53, I think, was the worst outcomes. As expected, there was significant overlap with complex karyotype, and importantly, this actually was the same regardless of the blast count, meaning that patients who had less than 5% blast and biallelic TP53 did very poorly, which I think has important implications in the clinic, while the monoallelic TP53s were actually preferentially assigned to other groups, again, consistent with those patients not behaving like the biallelic patients. del5Q MDS, again, I think there was a significant overlap here with the classifications where it was defined by the absence of complex karyotype or deletion 7q, and in the hierarchical classification, it comes after TP53. So biallelic TP53 is the first, then del5Q, and then SF3B1, which, as you heard from Dr. Hasserjian, we came up with the same conclusions that MDS with ring sideroblast who did not have SF3B1 did not have the same favorable prognosis and probably should not be lumped with those patients as currently is done in the WHO. And then the morphologically defined MDS, this groups basically, these morphologic entities failed to identify patients with distinctive genomic profiles as mentioned earlier. So we tried to generate a consensus-based recommendation to define these entities and to develop diagnostic qualifiers among this population. And this modified Delphi process, which involved 71 experts from 11 countries and 5 continents, basically recommended using disease entities for both prognostic and therapeutic impact, as well as those diagnostic qualifiers along the lines of what Dr. Hasserjian ended up his talk with, is that this does not supersede the genetic, classification, but I think it's important to, for now, to maintain the diagnostic qualifiers of whether the MDS is hypoplastic, whether you have fibrosis, whether it's therapy-related, but it does not replace the current class of flow-blast, XS+1 or XS+2, or also named MDS/AML. So this was the ultimate schema, which I think is a simplified version of what you saw. Understandably, there's a significant overlap with both systems. And here, actually, I like to say also that this classification has validated very well in terms of prognostic relevance to patients. And I would like to conclude by kind of talking about some of the other projects that we've been working with within the ICMDS. We have actually engaged with our pathologist colleagues trying to kind of standardize the way of diagnosis and pathology reporting for patients. We have ongoing projects looking at standardization of clinical trial reporting, which is all over the place. I mentioned yesterday that this, I think, great work led by Dr. Omar Burati has been just published in Blood, looking at trying to streamline the way we design clinical trials and the eligibility for those trials, and trying to increase their applicability to the real-life patient population beyond the clinical trials. And we are also working on a large database from many of you actually have been participating in this, called the Validate, across, again, across the world. And we have validated the response criteria, the IWG 2023. And finally, this project, I think, is ongoing, and I think is going to be very important as well, because the patient-reported outcomes, measuring them in MDS has been quite a challenge. And this effort led by Dr. Fabio Efficaci and Rina Bakstein, I think is going to be very important to try to develop this ICMDS PRO score, which will be in collaboration with the MDS Foundation, and it will involve a patient survey to understand the perspective from patients, as well as an expert survey. So with that, I would conclude that what we have done here is using a data-driven approach to generate strong evidence for the classification, and hopefully to develop a future classification. And using this AI approach, I think, has enriched this approach. And I would finish by saying there is really no one perfect pathological classification system. Every system is going to have some issues. And I think I would make the analogy to the IPSSM. There are a number of other very good molecular classification or molecular risk prediction tools, like the Cleveland Clinic and one from the Italian group. But as a community, we came together and we decided that we need to use one, and the IPSSM one is the one that we should stick with. And I think this is what we have to do in MDS. We have to come up with one system, and I personally actually don't care whether it's any of these systems and the new system. And I'm going to say that we are very happy, based on the new initiative, to try to finally harmonize and maybe take a little bit of credit to try to push this, rather than wait 10 years to have this kind of unified approach. And at the end, I would say, don't let the perfect be the enemy of the good. As Voltaire said, like, we really need to have one very good system that everybody uses, rather than multiple perfect systems according to the people who develop them. So thank you so much, and really appreciate the opportunity.
No, wait. Thank you so much, Amer. I guess we can take questions if the speakers are willing to come back, maybe? Yeah, just, please. Yeah, we do. There's one at the podium, and then... No, but... Well, one person can be at the podium, right?
Maybe we can start question. Maria?
I wait for the speakers to be seated.
Sit here. No, but...
Okay, too kind. Okay, thank you. It was a great session. I really think it was clarifying for many aspects. So what I would like to say is, and to comment probably, is that there is a sub-classification of the WHO that is MDS with fibrosis, that is really including only, apparently, only MDS with blasts. And this is not correct. And I would really like to stress this, because we encounter more and more MDS with fibrosis. Now, in many centers, biopsy is not routinely performed. We do it, and we see low blast and high blast counts with fibrosis. But because of the prognostic importance of fibrosis, I think we should stress this. And then just allow me another comment. I really agree with what Dr. Hasserjian said, but although I don't like AML-MDS, it sounds like we are back 25 years when we were trying to treat MDS and we failed, just because we were using the same approach as as for AML, but I really like what you said, that we should go for genetic characterization. So my idea and proposal, and I mean, you can take it or not, would be to use BLAST not as a continuum AML MDS, but more as a warning to see, we have BLAST, severe disease, let's characterize it really well to see whether we can go to one or the other treatment, and the biology is, it's really different. Sorry, I was too long.
I see Eva has a question. Oh, I'm sorry.
Ari was before.
Yes. Hi. Very interesting session. Now, what I realized here in this session, Ulrich's talk and Amer's talk really stressed, and I was struck in your last talk, Amer, about the importance of actually single lineage dysplasia and multi-lineage dysplasia. It's an incredible difference actually from the huge database. So are we too lazy to implement it, and do we want to spare the pathologists actually to look into it and really make up our mind? Do we think genetics are going to supersede it, and it's actually not going to be important? What is actually the reason why we don't stick to it too much?
Sorry, I can start. So I agree with you. I think also Dr. Hasserjian touched on this a little bit. When you look at it as a univariate kind of marker, I think it certainly stratifies. The question is, and this is where it comes, like, what is the goal of the classification system and how much overlap do you want it with risk stratification? So I don't know if applying the IPSSM, for example, how much unilineage versus multilineage would still kind of carry weight. But I do think my own opinion on this is the same way we describe it, is you have to have diagnostic qualifiers at the end of saying whether you have unilineage and this and multilineage, because ultimately this is how you collect all the needed data so that in the future you can put all of this together. Right now I can tell you it's again based on which system people use, they might just stop reporting, because in the WHO versus ICC, I mean, it's not needed. But I don't know if Dr. Ulrich wants.
Where's Ari? Here, okay. These guys here on the stage are not lazy ones, definitely not. But I think I alluded to it. The patient does not die from multilineage dysplasia, but he dies from infection and bleeding, and those with multilineage dysplasia have lower cell counts. So we should not use the cell counts as a classifier. WHO got rid of them because we want to get rid of the MDS unclassified. But we should keep in mind with regard to the single patient, is he pancytopenic, yes or no? And if there's no blast increasement, neither in the morphology nor in the flow, Arjan.
Exactly, that's what I alluded about, because the lazy pathologies are not existing, but if they are lazy, flow can discriminate easy. Yes, that's right. And that is in 30 seconds you see in a unilineage morphology, a lot of cases are dysplastic in a more monocytic range. So that is last comment today from that point, but important.
And we are mixing prognosis and pathology. Pathology is one thing, and they should give us the entire picture. They should say it's multilineage dysplastic or single lineage dysplastic, and whether you take that into account into a prognostic system is your thing. And also how you communicate afterwards with your patient is your thing. But I expect from a pathologist to give me all the information that they get from a specimen. And with this in mind, I will then sit down and say, oh yeah, they say multilineage and I see TP53, that's fine, there is a correlation, that's great. But I don't think we should drop things that we can see and depict just because we think that they should not enter into a pathological classification because of their prognostic or non-prognostic significance.
Agree totally.
maybe
Sorry,
Eva?
Rob.
Yeah, so I would like to just have a few words. One thing is that the reason, many years ago, not 100 years ago, but it was a long time ago, a number of excellent MDS pathologists actually made a blinded review of whether something had multi or single lineage dysplasia. I don't think you would like to see these R curves, and that was really the specialists. So there is we shouldn't have anything that doesn't provide excellent consensus when you want to get it out on the world. Secondly, I'm not sure we need a new classification. We just have to use the data points that we have. I mean, we have the fantastic classification tool now developed by Robin and Rashmi Kanagalan. You can add in whatever, and then you can press the button you want. And the reason for why I think this is that we are not done with the taxonomy yet. In 2015, we got to DDX41, and that was 3-4% of all patients. We had to rethink. And in 2020, we got the UBA1, and that was, then we had to go back. I'm not sure, there are more UBA1s to be found. There are more new things. So I don't think we need a new classification. We need a way of dealing with primary data so that you can adapt to whatever comes next. That is at least my understanding, because we are not done with the biology yet. I would like to perhaps hear Rob's comment on that.
No, I think I agree, and I think the next classification, I think, will not be the last one, right? There'll be further ones too, and we have to but the main thing is for it to be one classification. That's the first goal, and I think hopefully that will happen. And then I think certainly in the future there could be, as you say, new vexuses, new things that are discovered, things that come out of epigenetics or gene expression profiling. I think there are other modalities when we start doing single-cell sequencing. So I think classifications will always keep evolving, but the main thing is to do it in a unified way so that we're all together on it. I think that's...
I'm not sure that classifications are for the patients, honestly.
Maybe I can comment on your... sorry.
I'm a little bit teasing you, but I mean...
And just because in the US, I can tell you what happens now is actually patients are getting the report and they are literally putting it on ChatGPT.
Absolutely.
And they are coming to us and they are asking about every single word in the report. And I think it's doing them a huge disservice. And also the regulatory agencies, they have black or white. They don't understand, like it has to be this or that within the same thing with
that is then a political problem. It's not really a problem.
But the question is, what do you gain by having more than? What do you gain by having more than one system? I think that's a real question we have to ask. I think, again, for clinical trial, I cannot tell you how many meetings I had with trial sponsors over the last 2 years asking me which system should I use in my protocol. Should I use the ICC? I think Dr. Stensma mentioned yesterday that you can tell them to pick one. But in all honesty, this is not how it works, because again, there are a lot of implications of inclusion and exclusion, and so I do. And when you compare across trials and all of that, and I think it just doesn't have a clear purpose in my mind to have two different systems. I don't know.
And we are not all MDS specialists. I mean, we are applying.
You are. We not.
Yes, but we are not. As hematologists, we are not all MDS specialists. So I mean, in lymphoma, I'm happy when somebody tells me this is mantle cell lymphoma without me digging into the depth of the pathological report to see whether cyclin D1 and all this kind of stuff, and if my pathologist can tell me something, so it would be nice if we had one classification to guide also the hematologists, which may not be the MDS specialist in the field, to say, okay, in this case, that's what's usually be done.
So thank you so much for this discussion, and we have to move for the abstract. So. It's my pleasure to introduce the next speaker, Ulrich Duncavage. Thank you, from the US. The talk will be on the comparison of multidimensional flow cytometry versus high sensitivity sequencing for the detection of persistent disease in MDS patients. Thank you.
Thank you. Thanks to the organizers for inviting me to talk about this abstract here. And so I'll just briefly mention, I'm going to change gears a little bit. I'm not going to talk about classification. I'm going to talk about measurable or minimal residual disease, here referred to as MRD. This is it's great because it's agnostic to how the case was originally classified, either under the ICC or the WHO. And so for MDS, we use the IWG response criteria that relies on a combination of blast counts and peripheral blood CBC values. It's challenging to implement as a hematopathologist, and so one of the biggest challenges is blast counts in post-treatment MDS patients, and it can be very difficult to identify dysplastic myeloid cells from myeloblasts, especially post-treatment. CBC values too may be subject to cytotoxicity, and so it's difficult to separate that out from persistent MDS. Another thing to keep in mind is that blast count and molecular disease burden are not well correlated. And this is a figure from a paper that we published recently. This was from a trial of vosaroxin plus azacitidine in MDS patients. And you can see here with the blast count on the bottom axis here, and the VAF here, you can see there's really no correlation between blast count and mutation VAF. Another thing that we've identified at others as well is that CR, or complete response, is associated with clearance of mutations. And so there are different ways to do molecular MRD. You can break it down into two main approaches. There's a tumor-informed MRD, and that's typically when we do paired normal tumor sequencing, either whole genome or exome-based, identify somatic mutations, and then make probes to those mutations to follow the patients. We do this a lot for research studies, but it's impractical for most clinical applications. A panel-based MRD is a more practical way to do MRD testing, and that usually involves a fixed panel of commonly mutated genes, usually about 50 genes, and the same panel is run across all MRD time points. And the average MDS genome will contain about 300 to 500 mutations. About 10% of those will be present in the exome, and only about 1% of those will be present in a panel. And this is again from the paper that I mentioned earlier. We did very, very in-depth sequencing here, whole genome sequencing, to identify somatic mutations, and then made probes to track patients over time. You can see that the number of clones that are trackable with whole genome sequencing versus exome versus gene panel kind of falls off, especially when you get to the gene panel. And that changes the depth, or the way in which you can monitor patients. You can see with whole genome sequencing, when you track clonality across patients, you can see in the top plot there you can see an ancestral clone there, or persistent or clonal hematopoiesis clone in pink. You can see other clones that disappear that you can't track when you do exome-based sequencing, and you get very little ability to track these different clonal populations when you do gene panel-based sequencing. However, if you're interested in predicting response and looking for MRD, it turns out that gene panel approach works pretty well, and this is from a paper we published several years ago now, looking at post-allotransplant MDS patients, sequencing their day 30 bone marrows. If you do exome-informed MRD, you can see if you're positive at day 30 there in the red line, your cumulative incidence of relapse is much higher than if you're negative in the blue line. If we use that same data and just look at a 40-gene panel, you can see it looks pretty similar. The only difference is that a few patients are going to drop out, so you lose about 10% of patients when you go to gene panel-based sequencing. And so with that, we developed an in-house MRD panel. We call it MyeloSeq HD. It's a CAP/CLIA accredited assay launched in 2022. It has 40 genes. It's tumor only. It also detects chimerism. We use 50,000x total coverage error-corrected sequencing. That collapses down to about 7,000x total coverage. The sensitivity at diagnosis is limited to 2% VAF, and then for MRD purposes, we can go as low as 0.1% VAF for known mutations. In this study, we also used flow cytometry-based MRD. We don't run this in-house. We send this out to a lab, probably the largest lab in the US that does myeloid MRD. They have a maximum sensitivity of 0.02% cells. And this works from a difference from normal approach. In our study was a retrospective study. We looked at consecutive MDS patients where flow and molecular MRD were ordered over an 18-month period. This data was reported back to the chart, so clinical actions were taken. The MRD NGS data was reported either as MRD positive, MRD negative, or MRD negative with a persistent DTA mutation. The patients were treated with a variety of therapies, including hypomethylating agents, induction chemotherapy, and transplant. And there were 115 total paired time points that had flow and molecular testing. And you can see in this plot on the right, this shows you the time between the different collection time points. The average age of our cohort was 61. About 51% had blasts less than 5%. Half of the patients were transplanted, and all the patients were treated, so no observation in this cohort. Looking at the diagnostic sequencing results, you can see it agrees with previous cohorts. ASXL1, TET2 are the most commonly common mutations. P53 also features prominently. This is looking at the number of mutations per patient, and you can see that some patients here had no mutations, and so we couldn't track them. So we lost 6 patients from the cohort that couldn't be tracked with this assay. And here, this slide compares the molecular data to the flow MRD data. And so 40 of the 115 MRD time points were positive by flow. All 40 of those were positive by Myeloseq NGS, as you can see on the plot. If we look at the flow negative patients, however, 63% were also negative by Myeloseq, by NGS testing, but 28 patients, or 37%, were positive by Myeloseq NGS, and you can see those discrepant cases indicated there. You'll notice that the persistent DTA mutations correlated nicely with the flow MRD negative cases. And if we look at the VAF for the NGS MRD positive flow negative cases, you'll notice most of those are going to be low VAF, but there are some higher VAF cases, and I'll kind of give you some reasons as to why that is. If you look at the distribution, too, of gene mutations in these discrepant cases, you'll notice P53 is more common. It's enriched in this data set compared to what we saw for the full cohort of patients. And you can see where those fit in there. So both TP53 and SF3B1 mutations were enriched in this discrepant population. And so the next thing we wanted to know is, for these 16 discrepant patients, how many of those do these represent false positives, or do these patients, are they at higher risk of relapse? And so this kind of busy plot here is kind of showing all the different clinical, either transplant time points, treatment time points, blast count, as well as the different MRD testing time points. And so we found that 75% of these patients had a subsequent marrow with a blast count of greater than 5%, or had positive MRD by flow. The remaining 4 patients had very limited follow-up time, so it's very difficult to figure out what the status of those patients was. And I'll give you just quickly some examples here. This is a patient that was diagnosed with 8% blasts, 2.5% abnormal blasts. They had a P53 mutation here with a VAF of 12%. The pre-transplant marrow showed 0.2% blasts by the MRD flow assay. P53 was still there at 1.4%. And at day 100, the MRD flow was negative, but you can see that same P53 mutation was still there at 0.3%. And then day 300 post-allo, you can see the flow is positive, again at 0.3%, where the VAF is 2.2%. So you can see the VAF is generally much higher than the percentage of abnormal cells by flow cytometry. Another reason I showed you some cases where the VAF was actually pretty high, even though they were flow MRD negative. So a lot of this is probably due to dilute aspirates. Here's a good example here, or low cellularity specimens. This one was called negative by the outside lab. They estimated a limit of detection of 0.8%. You see the P53 VAF there was reported at 90% with an NF1 somatic mutation at 76% VAF. There's another case here with same thing. It's a hypoplastic MDS. This is taken after cycle 5 of azacitidine. It was a low cellularity specimen. The estimated limit of detection at 0.3%. Called it negative by flow, and you can see there's canonical SF3B1 mutations present at reasonably high VAFs. And then the last example of cases that we had were just really difficult phenotypes, I think, to identify by flow cytometry. So this is a patient that had multi-lineage dysplasia, a history of breast cancer, Burkitt lymphoma, anemia, and thrombocytopenia. They had a P53 mutation as well as a PPM1D mutation, multiple time points sampled by flow, all of which were negative. And you can see this patient had a complicated clinical course, including transplant. The VAFs eventually went down in the post-transplant setting. So in summary, panel-based NGS testing or MyeloSeq can be used in the clinical setting to monitor MRD status in MDS patients. In our study, 88% of patients were trackable by a small NGS gene panel, and 100% of flow-positive MRD patients were also positive by NGS. We found that persistent DTA mutations correlated with MRD flow-negative status, and that about 30% of flow-negative patients were positive by NGS MRD. And we also found that P53 mutations were enriched in NGS MRD positive cases. Thank you.
Thank you for the presentation. Is there a question in the audience? So maybe I have
Maybe
to...
I can ask a question.
Yeah, okay.
Yeah. So thank you, Eric. That was wonderful. I guess my question is for you, when we don't use disease-modifying agents, right, outside of the setting of transplant, venetoclax, or things that you expect would modify the mutational profile, are you guys still routinely doing this?
So we leave it up to the hematologists and oncologists to order the testing. In this particular cohort, we only looked at patients that were treated, but we run about 1,000 MRD NGS cases a year, so it's across, mostly in AMLs. But yeah, we run it.
But in MDS, I ask because our practice is that we actually don't. So unless the patient is receiving a therapy or is being transplanted where we expect the mutations to go away, we won't repeat the NGS unless we think the patient is progressing or they've been transplanted or received that, where we expect the mutations to go away. So I'm asking, like, should we actually be looking? Is there any prognostic value in looking at the VAF change? I know there was a paper that showed that reduction of VAF correlates with outcomes, but...
Yeah, you mean in patients that aren't being treated, that are just...
Right, if they're just receiving HMA, let's say, right? You don't expect the mutations to go away in MDS.
If they're receiving hypomethylating agents, I mean, we do see the mutations go away. And it takes longer. So usually by the end of the second or third cycle, we'll see some mutation clearance. They never go all the way away.
Yeah.
But they do get lower. And
yeah,
so
VAF reduction.
And yeah, so we can see that, and we showed that in several of our papers. You can also see, what I didn't mention here is that we can see the VAFs increase, usually before the blast count increases. And so what we found in our post-transplant AML study was that we could detect relapse about 60 days before clinical relapse by sequencing. And so that does provide some window for therapeutic intervention.
Okay, thank you. Other questions? No.
Thank you.
Just with that, thank you. So we will invite the last speaker, Dr. Xin Wang from China, who will speak to us about an integrated machine learning-based model for prognostication of patients with MDS.
Okay, thanks for your introduction. It's a great honor to be here to present our work today. The topic of my presentation is an integrated machine learning-based prognostic model for patients with myelodysplastic syndromes. First, I have no disclosures to report. Next, I will present my presentation in the following order. First, I will introduce the background, and then I will show the method section, including patient screening and machine learning algorithms, as well as the method of the variable selection. After that, I will use C-index and the time ROC curve to show the superiority of the new model and compare it with the previous traditional models. C-index evaluates the performance of the model, and the higher its value is, the better the model performs. And time-dependent ROC curve measures how well a survival model distinguishes outcomes at a specific time point. Let me introduce two patients. On the left, we see someone who appears frail and physically limited. On the right, someone who looks much fitter and more active. Now imagine both of them are diagnosed with MDS. They share the same disease subtype, similar mutations, and are classified as high risk by IPSSM. They are also considered eligible for HMA therapy, but their overall health is very different. The frail patient has severe pulmonary disease, and the other patient has no major comorbidities. Can we expect the same prognosis for them? Probably not. And this highlights a key point. The disease-related factors alone don't tell the full story. And frailty and comorbidities, and this is patient-related factors, they are also essential in prognostic assessment. And sometimes frailty is not obvious from appearance or age, so it requires structured assessment. Let's come to the problem. How should the patient's prognosis be fully assessed? There are three main tools currently available, and we validated all of them in our cohort. The first is IPSSM, which is widely used and incorporates both clinical and molecular data. It clearly stratifies patients by survival risk, and the MDS-specific comorbidity index, which assesses comorbidities, has been validated as an independent predictor of survival. And this is the 15-item frailty scale. It is a simplified frailty index. It adds independent prognostic model to existing models in MDS. Each of them provides important information, but separately. So our aim was to develop an integrated model that combines all these keys to since IPSS is a complex scoring system, we included it as one variable, along with 13 comorbidities and selected frailty measures from the FS15. In this study, we enrolled 812 patients from our center. After excluding 125 cases with incomplete IPSSM data, 687 patients were included in the final analysis. We performed correlation analysis firstly, and then randomly split the patients into a training set and a test set using an 80-20 ratio. We used a random survival forest algorithm to develop the prognostic model, which will be denoted as RSF model. And K-fold cross-validation was applied to optimize the model. Finally, we validated the model's performance using independent test set. We started with a correlation analysis. In generally, most variables were not strongly correlated, suggesting low redundancy. Only a few expected associations were observed, such as hepatic disease showing correlation with ALP and ALT. But that's not a major concern because the random survival forest algorithm is good at identifying complex interactions between factors. We selected the variables based on both their variable importance and minimal depth rankings. Now, let's take a look at the plot on the left. It shows the variable importance scores. These scores tell us how much each variable contributes to the model's predictive accuracy. The plot on the right combines variable importance and minimal depth rankings. It helps us identify variables that are not only important, but also appears only in the decision trees. Based on this approach, we finalized 8 variables for the prognostic model. First, IPSSM was included as a disease-related factors. Then we included 4 key comorbidities. They are pulmonary disease, cardiac disease, hypertension, and solid tumor. In addition, 3 factors from the FS15 was selected. This included self-care ability, MCV, and LDH. And in fact, the solid tumor is also a factor from the FS15. The RSF model was trained using 800 trees. As shown on the left, the prediction error rate stabilized after around 400 trees, suggesting sufficient convergency. Key hyperparameters were selected based on cross-validation performance, and the final model demonstrated strong internal consistency. So we assessed the model discrimination using the C-index. The RSF model achieved a C-index of 1.7.7 in the training set and 0.717 in the test set, both higher than IPSSM and IPSSR. The plot on the right visually compares the C-index values. Overall, the RSF model consistently outperformed both traditional model in terms of discrimination and in both training set and test set. We also looked at how well the model predicts survival over time using time-dependent ROC curves. In the training set, the AUCs were consistently high. What's more encouraging is that the test set showed similar or even better AUCs. This suggests our model is not only accurate, but also stable and generalizable over time. We then stratified patients into 4 risk groups using a decision tree approach that's based on the RSF score. As shown on the left, the cutoffs at 16, 53, and 91 define the 4 distinct groups. And the right panel shows the KM curves for each group. Patients in group 1 had excellent survival, while group 4 had the poorest outcomes. We then, to further test the robustness of our model, we performed the subgroup analysis by treatment. The RSF model maintained its prognostic value across different treatment subgroups, including patients receiving HMA therapy and immunosuppressive therapy. Similarly, the RSF model demonstrated a consistent prognostic value across different age groups. This Sankey diagram shows how RSF reclassified patients compared to IPSSM. As you can see, some patients originally classified as high or very high risk by IPSSM were reclassified into lower risk RSF groups. This suggests that our model may help refine risk assessment and potentially avoid overtreatment in certain patients. And let's pay attention to those patients. Those who were downstaged by the RSF model demonstrated significantly better OS compared with unchanged patients. Moreover, in groups treated with HMA therapy, the overall response rate was significantly high in downstaged patients compared to unchanged patients. And the incidence of febrile neutropenia with infection was higher in unchanged patients. So we developed a machine learning-based prognostic model for MDS that integrates both disease-related and patient-related factors. And the RSF model showed a better predictive performance than IPSSR and IPSSM, with consistent results across time points and subgroups. This approach supports a more comprehensive and individualized evaluation of prognosis in MDS and may inform better treatment decisions in clinical practice. Also, we hope to seek cooperation to validate our model in other cohorts if possible, or if you have any advice on our research, please contact us. This is my email address. And before I finish, I want to sincerely thank my mentor, Professor Hasserjian, and all our colleagues who contributed to this work. Most importantly, I thank the patients and the clinical teams who make this study possible. Thank you all for your time and attention.
Thank you so much. Is there a question? Yes, Moshe?
Yeah. Hi, Moshe Mittelman, Tel Aviv. Congratulations for wonderful work, very important. In order to make it practical for us, I guess this system, I guess you use something like the GBM model or something like this. In order to make it practical, we need to use it for the practical, particular patient. And what we will need is a simple algorithm that you can put the variables of the patient in each clinic, in each community. So I think this is still missing following your model.
So you mean it's complex, it's not simplified?
Well, if I understand well your model, and we are doing similar things, this is okay for the system, okay?
Yeah.
I mean, if you have a health insurance company with 1,000 people or 1 million people, they can use it for them. But you cannot use it if in another city, another community, the patient, you want to put the patient in the right prognostic subclass, you cannot do it by this. You need another simple algorithm based on that.
Yes. We now only have our Chinese cohort, and we really want some other cohorts from other city or other country, of course, to validate this. Yeah, thank you for your question.
So thank you very much for this presentation. It's an interesting approach. If I understood correctly, you entered the IPSSM score as a score. Did you also consider to maybe take in your random forest analysis all the components individually from the IPSSM in order to be able to see if there's correlations between, for instance, tattoo and cardiac events, which could be correlated, and then maybe one obviates the other? Did you consider to try that to see for correlations between gene mutations and frailty and comorbidities?
Oh, okay, that's a very good advice. And in fact, we used the IPSSM as one variable into the system because we think we want, of course, it combines variety and comorbidity. We hope it will be little similar for people to use. And we may, or where we have a patient, we may use the IPSM to assess their risk. But if we already have the IPSM, we only need to add a little comorbidities and the variety scores to inside, and we can assess the patient fully. So
potentially, if there were 100% correlation between a tattoo and a cardiac event, which is not the case, of course, but if that would be the case, then you could maybe leave out one of the analysis, if that would be complementary.
Oh, okay.
So it would be interesting to at least look at the correlations.
Yeah. I will do more research on this. Yeah, thank you.
Yes, Reinhard Stauder from Austria. I'm here.
Oh, sorry. Yeah.
Congratulations that you have now integrated patient-related factors in your evaluation system. So in my mind, it's a kind of validation of this FS15 score of Rena Bakstan. I do not know if she's in the room. I maybe want to address the point of Moshe. I mean, now we have talked a lot about all these classifications where we have a lot of extensive lab evaluations, and when we come to a scoring of 15 items, it obviously, or sometimes you argue that you want to have it simple. I mean, out of these FS15 values, you have body mass index, you have weight and height, and you have several lab values. So I mean, that's even, in my mind, that would be simple. Of course, you have to in addition, assess the functional capacity of the patient, and you have to check how is daily living. But in my mind, that is easy. So I do not understand why you always argue that patient-related factors should be simple. In my mind, they are simple.
Okay.
Congratulations to your work.
Okay, thank you very much. Yeah, and yeah.
Hey, question. This drive to predict our destiny is only purposeful if there is a fix to it. So, you know, that the precision of knowing whether a patient has higher or lower prognosis is related to our inability to treat the patient. So For example, if there is a dichotomy between prediction by one system and you have now better system, you show that patient is upstage to higher risk, does it mean that you overtreated these patients before and you should treat less? Because why to treat if you are not changing the prognosis? Prognosis is even worse. Or your fix to the issue is to treat more aggressive, but how do you know that the more aggressive treatment did not lead to the poor prognosis? So what is the goal there ultimately? And if a patient is upstaged, you say treat differently more or treat less intensely, or what is the issue? Similar with transplant. If a patient has high relapse rate, is it the point to do the transplant because patient has an aggressive disease, or is it the point of not doing a transplant because it would be futile?
Okay, but thank you for your question, and I know it's very I think I need a long explanation to this question, and maybe we can talk about it after the meeting. Thank you.
As a clinician, I like the idea of combining disease-related and patient-related factors in clinical decision-making. But there is one point I didn't understand. You showed a slide indicating that some patients with high-risk IPSS-M were downgraded by your system. How is this possible?
Sorry, I didn't understand very well, so can you...
In one of your slides, you showed that a few patients with high-risk IPSS-M when downgraded by your system. I mean, if the disease remains high risk, how is it possible that by using patient-related factors, the condition is downgraded?
This is a prognostic model, and in fact, we really want to use it to guide our clinical decision. And in fact, your question is very meaningful, and we are thinking about if we do the prediction model, we to predict the patient's prognosis,
okay, we will discuss.
I will think about it, and then we can talk about this. Thank you.
Thank you so much. Yes, maybe you can continue in front of the poster for the next session.
I guess. Thank you, everybody. Thank you to the speakers. The talks were wonderful, very informative, and I hope you all enjoy lunch.